So good morning and welcome to PCEP for November 2023. Thank you for joining us today. Today is going to focus on in two parts. We'll talk about airway management, kind of a high-level overview, the key thought processes involved, and then we're going to introduce crew resource management. Before we do that, I have a couple of brief updates. Housekeeping issues. If you have questions, feel free to raise your hand or post them in the chat. And I will absolutely want to get your feedback on this lecture. So first, we'll head into some brief updates. So CRESA has started to implement back CPR, where the caller will be instructed, if they cannot roll the patient, to begin CPR with the patient on their back. So I just wanted to give that as a heads up, so you're not surprised if you see that. Again, that's only if the people who are on scene are not able to roll the patient. And then second, both hospitals are participating in this statewide campaign. It's called the Washington Blue Band Initiative. We'll talk more about this in a later PCEP, but we're seeing an increase in deaths related to hypertensive disorders of pregnancy, so eclampsia, preeclampsia. And so there's a statewide initiative to give pregnant people who are at high risk for eclampsia these blue bands to note that. The initial focus is going to be on the postpartum patients because those are the ones that most often get missed and ultimately have the highest risk of mortality. But you will see patients who are currently pregnant with these bands as well. Key things for us are just to be aware of that, to key in on the blood pressure, and remember the dangerous blood pressure range for patients that are at risk for eclampsia and preeclampsia. One of the issues that's being worked out at Legacy is that the blue wristband also designates a blue wristband in the patient registration band is for a patient with a history of violence. So obviously we don't want there to be overlap there, and so they're working on making that distinction clear. Any questions about either of those updates? Okay. So I want to frame what we're talking about today on a high level. When I think about what goes into making a high functioning EMS system, these are the things that I think about. These are the pillars that if we get right, we will continue to progress. And if we ignore any one of them, we're going to have difficulty improving the care that we deliver. So obviously the cornerstone of what we do is high quality clinical care. That means doing stuff that's proven to work, not doing stuff that's proven not to work, and delivering that care in a repeatable, safe way to the extent possible. Obviously, ongoing learning is part of it. That's both what we're doing today, but making sure that you are getting feedback on the patients that you take care of, getting the chance to increase your clinical knowledge by learning what happened to the patient. And that's a major initiative that we're trying to do on a more systematic way. And the ultimate goal is for you to be able to get the outcome for every patient that you touch. What happened in the hospital? What was the long-term course? That's going to be a long-term project, and I can't say we're going to have that in a month, but I think that's a critical part of that ongoing learning and developing our clinical expertise. Obviously, we have to do everything in our power to support crew health and safety. So that's both your physical health on scene, staying safe from violent patients, being able to disengage in a violent scene, having protocols that are as simple, repeatable as possible, and expose the provider to the minimum amount of risk. But that's also long term. This, I don't need to tell you that the job you do is really taxing on both physical and mental health. And so we want to continue to pay attention to supporting with physical and mental health in the long term. And then the final pillar that I think about is effective teamwork. How do we take all these things together and function as an effective team? What are the components of making an effective team? How do we continue to get better in working as a team? And so today we're going to focus on two of these pillars. So first, the high quality clinical care. We're going to talk about airway management. And then with respect to teamwork, we're going to talk about crew resource management. And both of these are going to be high level overviews, how we think about the problem, the framework, and we're going to get into a lot of the details both in subsequent lectures and in skills sessions. But my vision is that with respect to crew resource management, we inject a little bit of this throughout the year in PCEP and then in skills sessions. With that, first, we're going to go into airway management. And so I'm going to build on things that we talked about last month. So ultimately, what we're trying to do here is we're trying to maintain gas exchange. The brain is very sensitive to drops in oxygen, and we need to be able to expel carbon dioxide to maintain normal physiology. So ultimately, what we're trying to do is to maintain gas exchange. And in order to do that, we talked about last year, you need the airway, you need negative pressure, you need surface area, you need oxygen and carrying capacity. And so when we think about airway management, we need to think about maintaining each of these. How do we maintain each of these as continuously as possible? We want to be proactive about how we manage the airway. So Ron Walls, who is the founder of the National Emergency Airway Registry, says that airway management is the foundation on which the resuscitation process rests. Charles Stewart says there are few more important tasks in emergency medicine than airway management. Whatever method is used must be effective, for the problem airway does not allow the luxury of waiting until the physician arrived until the problem has cured itself. So we want to be thinking, where's the airway right now? Where is the airway going? But there's a reason that I don't title this section intubation. This is not about intubation. This is not just about getting a tube through the vocal cords. This is about how do we maintain tissue perfusion? And to maintain the tissue perfusion, we need to maintain oxygen saturations, we need to maintain end-tidal CO2, we need to maintain blood pressure. All of those things together maintain tissue perfusion. So what's the cornerstone of airway management? BLS. There's a reason that this is the first thing that we learned as EMT basics. This being able to do good bagging is going to decrease the temperature of any scene. It's going to give you more time for anything else that you need to do. And often it is the thing that saves patients. So it is a bag valve mask with a PEEP valve and then some airway adjunct. And it often happens in EMS that this task gets delegated to the most junior person. And if the junior person is able to do that, but the most senior person on a scene has to be overseeing this process, has to be troubleshooting this process, because this gives us more time to do everything else that we need to do. That said, there are sometimes we make a decision that we're going to manage the airway using advanced methods. First method that we're going to talk about is RSI. So why do we RSI? There are three reasons we should be performing RSI. The first one is for a patient's inability to protect or maintain their own airway. This is typically because of a neurologic issue, head injury, status epilepticus, stroke, overdose. These patients generally are physiologically fairly stable, but we need to maintain the patent airway. Second reason is failure to oxygenate or ventilate. These are the patients that tend where the physiology is the biggest challenge. They either have or are, or we expect that they're going to soon have respiratory failure. And so we are intubating to treat respiratory failure. And then the final is the expected clinical course. This can be burns, but this can also be a case of angioedema, where when your clinical expertise says this airway is only going to get worse and my chance to manage it is now, then that's an indication for RSI. The way that I think about RSI is that you're taking a patient that's breathing and you're taking away their ability to breathe. So it's like jumping out of an airplane. You have something that is going, even if it's, an engine is failing, something's not going well. You are taking someone who is breathing and you're putting them in a state that's not breathing. So when you think about how we manage this, think about what's the acceptable failure rate for a parachute. We have to have both plan A, plan B, plan C. We have to know how we can get this person. If we're going to take away their ability to breathe, then we have to know how do we get them back to breathing safely. So so we identify a patient that requires intubation. So pre-oxygenate the patient either with CPAP or a max flow non-rebreather, or if they're adequate respirations, or if they're inadequate respirations, then BVM with PEEP. The things that fix hypoxia are FiO2 and PEEP. So we're going to do everything that we can to pre-oxygenate the patient. If we can denitrogenate the patient, so maintaining a SAT of greater than 94% for 3 minutes, then we can go ahead with RSI. Then if not, then we're going to talk more about DSI later, how we do a procedural sedation to allow for pre-oxygenation. When you think about RSI, think about the relative contraindications. So in general, in cardiac arrest, we typically don't need the drugs to get the patient intubated, and we typically, the key thing in cardiac arrest is high quality CPR. So we typically manage with a supraglottic airway, and so there's very rare that a patient in cardiac arrest needs drugs for RSI. Physiologic instability, because ultimately what we're trying to do is we're trying to maintain tissue perfusion. And so we want to resuscitate before we intubate. And the risk of taking away someone's breathing when they're physiologically unstable becomes much greater. We want to do everything we can to minimize that risk. There are some deeply comatose patients with absent tone where we don't need medications. That should be relatively rare because we know that in a patient that has any tone, by pushing a paralytic, we get much better intubating conditions. And then the final thing where we take an extra pause before making the decision to RSI is when the patient needs to hyperventilate to maintain their physiology. The classic examples of that are DKA or an aspirin overdose, where the patient is breathing off a lot of CO2. They have a powerful metabolic acidosis, and then it is very difficult to match that with our respirations. If you do, then the key thing to do is to look at what their end tidal CO2 was before intubation and get as close to that after intubation. But we should take a pause before we intubate anybody in that situation. So when we do make the decision to RSI, the key is attaining first pass success. We know that with each subsequent airway attempt, the risk of complications goes up and the chance of success goes down. So and I just wanted to give thanks to Jason Jensen, previous clinical education supervisor at AMR, for this slide and a few of the other slides here. I think he explains this stuff very well. So an RSI is not a rushed procedure. The only rapid thing is that we administer the medications one after the other. So Preparation is key, having all the equipment. We know that a video laryngoscope and a bougie are proven to improve first pass success. Um, in most cases, a device that allows for both direct visualization and video is the ideal starting point, but there are many cases where you may choose to use a hyperangulated blade. But we know that video improves the chance of success. We know that using a bougie improves the chance of success. Just remember, with a hyperangulated blade, you also want to have the bougie be hyperangulated. So pre-oxygenation, or washing out the nitrogen, as we discussed earlier, and then positioning the patient. So both having the external auditory canal to the sternal notch and having the patient as upright as you can arrange for, so that fluids flowing downhill, you're maximizing the respiratory status. So key points about RSI: the reason we give the medication is to give us optimal intubating conditions. We've studied, sedative only intubations, and some people thought, oh, maybe this will be safer because we're not paralyzing the patient. What we find is that we're less successful with sedative only intubations because we don't get that muscle relaxation that we get with the paralytic. Our chance of success is much better if we resuscitate before intubating. And then remember, the paralytic doesn't provide any sedation. We need to provide post-intubation analgesia and sedation. Okay. So what do we do when the patient is already in free fall? We have this narrow window. They're already hypoxic. This is the situation where we start to think about delayed sequence intubation. And so I'm going to run through that and then give a clinical story from my recent experience. So what is delayed sequence intubation? It's a break in the sequence of RSI to allow for adequate pre-oxygenation. We're administering a sedative that doesn't blunt the respiratory drive. Why do we do it? It gives you and the patient a chance to breathe easier. It allows you to resuscitate before moving on to the next steps in the sequence. And it reduces the risk of the adverse events from intubating a hypoxic patient. So this was from a shift 2 weeks ago. I was taking care of a 45-year-old man who presented with cough for 2 days. Ultimately had ultimately had pneumonia. Initially didn't look too bad, but I had him on a high flow nasal cannula. He initially was at 50 liters of oxygen and 50% FiO2, looking fairly good. And then over the space of about 30 minutes, his oxygen requirement just kept on climbing and climbing. Ultimately, we had him on a high flow nasal cannula at 60 liters of oxygen, 100% FiO2. He's saturating at 83%. And I was working with a paramedic intern that day, and the paramedic intern was like, is this a chance for me to intubate? I was like, let's see if we can resuscitate him first. If he stays this hypoxic, I have to have the most experienced person do it. And so we put the patient on CPAP, initially at a pressure of 12, and left him like that for 3 minutes. Saturation came up to 88% on 100% FiO2, CPAP at 12. Like, man, this is going to be dicey. And I think looking at the paramedics and saying, not looking good. But I said, okay, let's try one more thing. We're going to turn the CPAP up to 16. And it was really difficult, but I made myself wait. I just went to go check briefly on another patient because I knew if I didn't do that, I would have a difficult time waiting. And left him at a CPAP of 16 for 4 minutes, and his oxygen saturation was 96%. Paramedic student intubated the patient. It was his second intubation of a real patient. Everything went fine. And so taking that extra time to pre-oxygenate changes this situation from I have to have the most experienced person and everything needs to go right to I can have a learner do this because I've made this situation so much safer just by taking the time. But it does take patience, and I personally find that difficult to wait because you wanna act in a situation like this. So referring back to protocol, so a patient's got a SAT of less than 94%. Um, Then we give ketamine 2 milligrams per kilogram with a max dose of 200 milligrams. Repeat the pre-oxygenation. So if the respirations are adequate, CPAP. If the respirations are inadequate, then BVM with PEEP. And just remember that more and more PEEP. It's what the pulmonologists call a recruitment maneuver. You get more alveoli into the mix. You get the patient to the best oxygenation possible. Then if you can maintain that saturation, then you're essentially in the situation you've removed some of the key physiologic barriers, and then you can give the paralytic an intubate. Remember to do your apneic oxygenation. That's going to continue to extend your apneic time, and um, and then you're in that safe situation. If you cannot maintain that, then then ventilate the patient with a supraglottic airway. And what we're essentially saying in that situation is they're too physiologically unstable for us to take their breathing away. We're going to maintain oxygenation and ventilation as well as we can, but not give the insult of temporarily taking the breathing away. So thinking just a little bit more about the indications of the hypoxia. And as you know, many of these patients from the hypoxia or the hypercapnia can be really agitated, and that can make it difficult to pre-oxygenate them. So the ketamine can be very helpful in that situation. Uh, and just remember what is adequate respirations? Adequate respirations is they have enough respiratory drive to improve their physiology, and if they don't, then we're going to take over the respirations for them. So final points. So after you get to 94%, that's when you wait the 3 minutes so you have that time to fully wash out the nitrogen. At the same time, remember, we're trying to maintain tissue perfusion. So you're going to do everything correct hypovolemia, address hypotension if you have it. And then if you can't get to 94%, then supraglottic airway. And if you need a paralytic to get them to tolerate that, you can do that. In most cases, the supraglottic airway will be enough. And with that, any questions about airway management principles before we go on to crew resource management? Okay, so I'm going to introduce this with a video, and then we'll go into a little bit of a conversation about this. Let me get the video up. Okay. Apologies for the delay. I'm going to stop for a second, put the video on the screen.
Dr. Mocht, I think we're missing some audio from that.
Okay. Okay. I'll switch this up, make sure we can get it. So you're not getting the audio right now. Okay. You getting audio with this now?
No. No, I'm not hearing anything.
No,
Okay.
no audio.
Okay. So my apologies for the technical problems. So I'm gonna summarize this video, and we'll go back to the presentation. So this is a video of a crash that occurred in an airplane, in which the co-pilot knew what was going on, but the pilot wasn't taking the input from the co-pilot, wasn't listening to what was going on, was doing things that were belittling the co-pilot. So there was no effective communication there. Ultimately, the ultimate outcome was that the plane crashed. So I'm going to go back to the presentation. Okay, can everyone see my screen now?
Yes.
Okay, and again, apologies for the technical issues, but so the crew resource management is something that comes out of the aviation world, because they recognized that there were preventable plane crashes where the issue was communication between the crew members, that different crew members had the right information, but it wasn't put together in the right way to get to the right outcome. And so this has been so this initially was developed in aviation, but it's spread to healthcare because they're obviously things that are generalizable. And obviously this implies in our patient care role, but it also, I mean, all of you do things that are difficult that don't directly involve patient care, like driving with lights and sirens. And so having this model of teamwork can be extraordinarily helpful, but it's a skill that we develop, and it's a skill that we develop as a team, because we need ways to communicate, and we need ways to problem solve when we're having difficulty communicating. So what are the components? So knowledge, being able to share this mental model of what's going on. And if it's only the leader of the team that has that mental model, but it's not being shared with other team members, then it's very difficult for the other team members to contribute meaningfully to what's going on. Developing attitudes that allow for the possibility, one of the key things that I have to consider as a team leader in the emergency department, I could be wrong. And I have to invite other people to let me know that I'm wrong and to let me think about what I'm missing. Part of it is performance. So how do we perform well? How are we adaptable? How are we accurate? How are we productive? And then how do we do this sustainably in case after case after case? So those are that's the framework. And then there are key competencies that that support that. So some of it is team leadership. So effective leadership of a team that's formed on the fly. Situation monitoring. How do we stay aware of the situation that we're in? How do we monitor? How do we recognize changes in the situation? Mutual support. How do we function as a team so that we can divide tasks so that we can recognize things that are being missed? And then finally, how do we communicate? What are the ways that we effectively get these messages across? Because we can't just take communication for granted. So these are the key skills in crew resource management: the communication, the team leadership, the situation monitoring, and the mutual support. So I'm going to go through each one of those briefly, and then we'll go into each of these in greater depth in future sessions. So with communication, this is a kind of geeky dorky slide, but the idea that I find that I have to remind myself about is that, we take speaking and receiving information for granted, but we often forget that there's some noise and there's some things that are lost in translation between one communicator and another communicator. And so, for example, if I misread the social context that the patient is coming from, or that one of my colleagues is coming from, it's going to be difficult for me to communicate effectively. If I miss the cultural context that, in this family structure, this individual has a position of honor that I didn't understand and that I missed. Um, and then what is the physical and the psychological context? Am I communicating, did I just wake up a surgeon who is asleep, or who's, I'm talking to someone who's busy in the operating room? And then what's our relational context? Did I make him angry the last time we talked? How are we gonna get this across effectively? And so recognizing these barriers to communication and coming up with strategies to overcome them, figuring out how we effectively communicate. And one of the key skills in communication is closed loop communication, meaning that I send a message out and that someone gives that message back to me so that I know that it was understood. Okay. Team leadership. And some of that is, so we talked about sharing the mental model, setting the goals for the team, defining the roles and responsibilities, defining the plan of care, figuring out how we share workload. One of the key things that a team leader can do is recognize when one individual is getting task saturated, and figure out how can we share workload so that that individual has more capacity. And then what are the resources available? What other resources do we need to bring into the situation? Situation monitoring is a process. This is this global awareness where you have an individual who's monitoring the situation. For example, okay, I'm on this call with this psych patient. Psych patient's getting additionally agitated. Now family members are getting agitated. So then that individual is aware of the situation, and then we contribute that to the shared mental model. Like, hey, hey, did you see that the family member is really starting to get angry over there? Or, hey, did you notice? Look, there's a weapon in the back of the room. That kind of situational awareness is something that we want to continue to develop, both in terms of keeping the patient safe and keeping us safe. And then talk about mutual support. And so this assistance with tasks, that's not just coming from the team leader, but coming from the individuals. You can notice that the person next to you is having trouble with an IV, or having trouble managing getting the gurney turned around. Offering that assistance, offering useful feedback, something that you can take and turn into action. Um, asserting that you know, asserting yourself and advocating for the patient. One of the strengths of our system is that we have multiple paramedics. It would be crazy to think that multiple paramedics are going to agree exactly on the assessment of the patient and the and how we're going to approach the patient. But talking about how we effectively communicate, how we effectively disagree, so that we're incorporating both points of view and coming up with something that's effective for the patient, that is difficult. And that is a skill that we want to develop. Managing conflict. The conflict in patient care is unavoidable. We see things differently. We're going to approach things differently, but having multiple points of view is much better than only having one point of view. And that that model of being able to disagree effectively and being able to work through difficulties in communication is a key skill of an effective team. Questions about crew resource management before we move on to the take-home points? Okay, so I'm going to review the take-home points. So goal of airway management is to maintain constant tissue perfusion. That means airway management is not just passing the tube through the cords, but maintaining blood pressure, maintaining oxygen saturation, maintaining end-tidal CO2. When we do intubate, we intubate for airway protection, respiratory failure, or expected clinical course. We use DSI to maximize patient safety in patients that do require intubation. And then finally, key skills in crew resource management are communication, team leadership, situation monitoring, and mutual support. So that's what I have. I will continue to develop this over the coming year, but I absolutely want input, particularly with crew resource management. If there are people who are interested in working with me to develop how this looks within our system, I'm eager to work with you. And so I welcome input. And then finally, I want your feedback to make these lectures better. You can scan the QR code. I will also put the link into the chat, and we'll use your feedback to improve future sessions. So that take any questions, and I'm grateful for the help.
Thank you, Dr. Mox. I just wanted to make a quick little comment, real quick. I appreciate some of the preliminary material for this presentation was sort of directed by you all by filling out the survey we asked you to do last week, and just wanted to give a shout out and thank you for everyone who put the 5.23 minutes that it took to do that particular survey. Really appreciate it.
No, I second that. Yeah, incredibly helpful to know kind of how to pitch this, and I want feedback on how we did, and what you want to see going forward. What's going to be useful, and the key thing is to make this clinically useful, to make your we want this to make your next call better.
Thank you, Dr. Mott. I think this is going to be an interesting project to watch as it develops.
Thanks. Okay. Well, no further questions, we'll wrap. And again, I really appreciate your input. Thank you for what you do.